Hello again. It's time to go through psychosocial health and illness. So, this chapter, which is chapter 13 in your book, introduces you to the key concepts of psychosocial health, self concept, anxiety, and depression. The interactions of the mind and body are continuous and complicated. One of the strengths that we have as nurses is that we can go beyond a biomedical or disease-oriented focus to care for the whole person, and that's called holistic nursing. Nurses recognize that patient responses to illness are influenced not only by physical pathology, but also by the person's psychosocial health and its relationship to the overall wellness of the patient. Your patient's psychosocial needs are just as important as their dietary requirements or their level of pain. So, psychosocial theory, there are many theorists, but you can think of the psychosocial theory as a method of understanding people as a combination of psychological and social events. Again, there are a lot of theorists throughout history, and we've talked about Abraham Maslow in the past. Maslow developed a widely accepted hierarchy of human needs and motivations. So the bottom of the pyramid, if you remember Maslow, the essential needs of air, water, and food have to be met before higher needs can be met, such as learning, creating, understanding, self-fulfillment, self-actualization. So in order from the most basic to the highest need, Maslow's hierarchy includes physiological needs, safety and security needs, love and belonging needs, self-esteem, and self-actualization needs. The term psychosocial, again, is both psychological and social. So a person's psychological state interacts with his social development and position in the society to contribute to his overall or psychosocial well-being. So patient responses to illnesses are influenced by the relationship among that pathology, his psychosocial health, and overall wellness. So here's a box of psychosocial influences on health. What is the person's socioeconomic status? What type of support systems does one have? What are some coping mechanisms that a person uses? What kind of crisis management system does the person have beyond those coping skills? What type of emotional well-being does this person have? What is the person's social network? Do they actually get out and interact with people, or do they strictly just do Facebook? Has the person had success? And what type of success? Do they have family? What kind of diet are they on? Are they an educated person, or were they just able to finish a few grades in school and then have to quit school to help their family financially? How mature is the person? What is the person's career? Does the person have friends? What goals does the patient have? Is the person physically well? What type of environment does the person live in? And does the person have pets? And why are pets important? Pets are important like friends are important. These days we have pets that are certified to support certain people. So what is self-concept? Self-concept is somebody's overall view of themselves. It's a complete and unique answer to the question, who do you think you are, or who do I think I am? Self-concept forms out of a person's evaluation of his physical appearance, sexual performance, intellectual abilities, success in the workplace, friendship and approval from others, problem solving and coping abilities, unique talents, and so on. A person with a healthy self-concept has a mostly positive perception of these evaluations of self. Your book mentions a dynamic self. The dynamic self forms and changes in response to our environment. Who we are is subject to change through social and environmental influence. And the anthropologist Margaret Mead is the one who stated that we discover who we are through a lifelong process of differentiating from and comparing ourselves to others. So how is self-concept formed? There are different steps, and there are 4 listed in your book. As an infant, we learn that we are physically different from our environment. So we have to learn, it's me, not me. This is what's me, and this is not me. So you see a baby a lot of times like looking at their hands, they put everything in their mouth, they look at their toes, they look at their environment, and they explore their environment. So they're trying to differentiate themselves from their environment. As a child, the child internalizes others' attitudes about themselves. Who do they say that I am? Are they saying I'm a good girl, or I'm a good boy, or I'm a bad girl, or I'm a bad boy? Who do they say that I am? So they're internalizing others' attitudes about them. And primarily, that comes from parents and other children around them, such as in daycare centers or at the babysitter. As a child and adult, we tend to internalize standards of society. How do I compare to others? What do I have that they don't? What do they have that I don't? How do I compare to somebody else? As an adult, self-actualization and self-adjustment occurs. This is who I am and who I will continue to be. So those 4 stages are how self-concept are formed. Factors affecting self-concept. Gender. Girls typically rate teamwork and cooperation as important to their sense of self, whereas most boys place a higher value on individual achievement. Physical appearance seems more important to girls, and they may be less satisfied and more self-conscious throughout life because of this. As role expectations and career choices for both men and women expand, these gender-based differences in self-concepts may fade. Developmental level. As we mature, our self-concept becomes more inner-guided. That is, others, for example, friends, the media, etc., have less influence on our ideas about who we are. We become less likely to view our failures and shortcomings as evidence of worthlessness and more likely to see them as challenges common to humans everywhere. Then we look at socioeconomic status. The family strongly influences a child's developing self-concept. As an infant's sense of self-permanence develops and becomes stable, like when they figure out this is me and this is the environment, so they've figured out their sense of permanence. Categories of self begin to emerge. These include notions of gender, values, and a sense of having a distinct place among family members. Social identity is first fostered by interactions between infants and their parents and broadens in toddlerhood through relationships with siblings, grandparents, and extended family members. For older kids, peers become more important than family in this respect. Then you look at the locus of control. There is an internal locus of control, and an external locus of control. People who allow their inner voice to influence their self-concept have what is called an internal locus of control. Such people feel they can exert control over their lives. They take appropriate responsibility for their life experiences and for their responses to them. This enables them to interpret unexpected adverse effects in more positive light. Now, those persons with an external locus of control have attribute the control of their situations to factors outside themselves. So, other people, institutions, and God. They may feel they lack the ability to change what happens to them. Components of self-concept. Body image. Your mental image of your physical self, including physical appearance and physical functioning. Both cognitive, meaning knowledge, and understanding and sensory input influence body image. Our understanding is in turn influenced by family, social, ethnic, and cultural norms, education, and exposure to alternative values. So what is your body image? Role performance can be identified as the actions a person takes and the behaviors they demonstrate in fulfilling a role. Instead of expectations, role performance is the reality. Personal identity is your view of yourself as a unique human being, different and separate from all others. Identity develops over time, beginning in childhood when you identified with your parents, and then later with teachers, peers, and others. Unlike body image, which is expected to change over time, personal identity is relatively constant and consistent. It is culturally determined and learned through socialization. Self-esteem, in the simplest terms, is how well a person likes himself. It's the difference between the ideal self and the actual self. That is, between what I think I ought or want to be and what I really am. The balance between our self-expectations and our true abilities can be precarious. When we succeed beyond our ambitions, we experience a high sense of self-esteem. But when we aim for an ideal self beyond our capabilities, we risk loss of self-esteem. The elder client's daughter is vice president of a large company. She is experiencing great conflict in trying to care for her mother while managing her work-related responsibilities. In planning to help the daughter, the nurse focuses on which component of the daughter's self-concept. What is this daughter trying to do? She's trying to fulfill many what? So the correct answer is B. The data suggests that the daughter is experiencing inter-role conflict. So she's trying to maintain different roles, taking care of her mother, but she's also the vice president of a large company. So she has a lot of conflict in trying to do both of those things. Body image is the mental image of physical self, and it's influenced by ideal versus perceived and actual body image. So ideal versus perceived and actual body image. People do not always see their own bodies as objectively as others see them. Some psychological disorders interfere with the ability to interpret sensory data objectively. For example, people with eating disorders, anorexia nervosa and bulimia nervosa, see themselves as fat even when their mirror reflects and other people see a normal or even an emaciated body. The closer the match between a person's ideal body image and sensory input about his or her body, the more positive the person's body image is likely to be. So if you have never seen anyone with anorexia nervosa or dealt with anyone with anorexia nervosa, it has always amazed me that they do perceive themselves as fat. I had one woman many years ago that I cared for, and she thought she was fat. And she looked like a skeleton. So again, our body and our mind work together in very mysterious ways. Appearance and function of the body. A physical disability such as blindness, deafness, or paraplegia can interfere with the development of a positive body image. Children born with a physical disability have a high incidence of poor self-concept and depression. This is partially due to social values and the child's inability to form adequate social relationships, but it may also relate to the person's perception that he has low social value. In contrast, an attractive appearance and superior functioning, whether in a career, sports, or academics, contribute to a positive body image. But again, cognitive understanding can increase self-concept, even in people who are average in appearance or achievement. Gradual versus sudden body changes. Gradual changes in physical appearance occur naturally throughout life as the body matures and grows old. Most people adapt to such changes relatively easily, especially because their friends and colleagues are aging, too. In contrast, when changes in appearance or functioning occur abruptly, such as following a traumatic accident, having a burn, that type of thing, they are much more difficult to accept. Denial, anger, self-hatred, and despair are a few of many reactions that can follow such an abrupt change in body image. Role performance. The actions a person takes and the behaviors demonstrated in fulfilling a role. So there are many roles that we have in our lives. Many of you are mothers or fathers, you're students, you are, breadwinner, you are nurturer, you are nurse, you are counselor, everything. There's so many roles that we have. So sometimes our roles conflict. So, and we have problems with that. Personal identity is your view of yourself as a unique human being, different and separate from all. Our personal identity, once again, we've discussed this already, but it's relatively constant and consistent. So your personal identity is your view of yourself. You're unique, you're different and separate from everybody else. So this identity, again, develops over time, begins in childhood when you identify with your parents, and then later with teachers, peers, and others. Self-esteem is how well a person likes oneself. Psychosocial assessment. We look at the biological, the psychological, and social details of a person's life. What are their functional abilities? Self-efficacy, like how well can they take care of themselves? What are their family relationships? And then what are their relationships with the wider social environment? What is their friendship network? Who are their colleagues? All of those types of things. Psychosocial assessment. Again, interpersonal communication. How do people communicate with one another? Or how does your patient communicate? Are they introverted, extroverted? Can you tell? Do they like to keep to themselves? Do they want to even talk to you? What are their social resources and networks? Do they understand their current illness? What are their usual coping mechanisms and what are their health priorities? In assessing clients who may be experiencing a depressive disorder, the nurse's top priority is to determine which of the following: onset and severity of the symptoms, risk of self-harm, previous history of depression, family and community supports. What do you think is the most important there? Depressive disorder. The answer is B. It would be most important for the nurse to assess for life-threatening behaviors such as self-harm, which could include suicide. So be particularly mindful of that. So there's a assessment continuum here when we are assessing our patients. Do they have mild symptoms or do they have severe symptoms? Mild symptoms in when you're considering whether somebody has depression, are they just sad or do they feel like they have total despair as far as their behavior or their mood? I'm sorry. In their behavior, are they crying or have they totally shut down? In their thoughts, are they distracted, which is more of a mild symptom? Or do they have delusions and confusion and self-blame, are severe? As far as their physical manifestations, do they have low energy? Or on a severe scale, do they have poor hygiene, anorexia, insomnia, or hypersomnia? So you have to look at a whole bunch of different things. Psychosocial diagnoses. Do they have interrupted family processes? is our parents getting divorced, that type of thing. Even something positive like an adoption in the family is an interrupted family process, so to speak. We're not really interrupting anything, we're adding something, but still that is a stressor. Family coping, the usual support from a significant other is either compromised or disabled, causing a significant health challenge. Parental role conflict. A parent shows significant role confusion and/or conflict in response to crises. Ineffective individual coping. The patient fails to comprehend and effectively judge stressors when he perceives incorrect or dangerous life choices as normal, and when there is an inability to use available resources. There's an inability to identify the strengths and resources which may be secondary to low self-esteem. Post-trauma syndrome. There's a maladaptive learned response to a traumatic and distressing event. So these are all diagnoses. What we need to do as healthcare workers is determine the cause of these problems that people are having and how it is affecting them physically or mentally. Other psychosocial diagnoses. Risk for loneliness. The person separated from persons, culture, objects, or environments to which a person may have ongoing attachment. Social isolation. The person experiences significant aloneness, and that has a negative impact on health or perceives the isolation as a threat to health. Risk for violence directed at others, situation in which a person threatens or uses aggression or violence to harm others. The intention of harm may not be limited to physical harm. It may be also emotional harm. And there is impaired social interaction, which also goes along kind of with social isolation in a way. But impaired social interaction can include persons who are sociopathic. Self-concept diagnoses. Chronic low self-esteem. This is a diagnosis in which the person expresses ongoing and long-lasting overall self-dissatisfaction and negative self-appraisal. Etiologies include depression, mismatch in ideal and perceived self, dysfunctional family, anxiety, or failure to adapt to change in physical appearance or functioning. So again, those people who have maybe an accident, a bad burn on their face, whatever, can contribute to chronic low self-esteem. Situational low self-esteem. The person exhibits self-disapproval and negative self-evaluations as a specific reaction to loss or change. Disturbed personal identity. Negative and incorrect assessment of self-identity and inability to determine boundaries between self and others. Etiologies include distorted perceptions of self, such as occur in certain mental illnesses, loss of health, limb, physical appearance or functioning, or a dysfunctional family. Disturbed personal identity. The next diagnosis with self-concept is ineffective role performance. A person experiences or perceives difficulty in fulfilling a usual role, or there is a mismatch between role expectations and role performance. Etiologies include job demands exceeding abilities, inadequate resources or support systems, family conflicts, domestic violence, unrealistic role expectations, lack of a role model, substance abuse, cognitive deficits, illness or disease, low self-esteem, pain, fatigue, and cognitive deficits. So there again, ineffective role performance. Disturbed body image as a self-concept diagnosis is where an individual has a confused image of his physical self or negatively evaluates his body or an aspect of it. Etiologies include loss of functioning or appearance, such as with acne, scars, breast removal, amputation, that type of thing. It can also, disturbed body image can also relate to eating disorders, gender conflict, or personality disorders. So there are psychosocial, self-concept, and self-esteem outcomes. There are approximately 30 NOC standardized outcomes to describe psychological well-being, psychological adaptation, self-control, and social interaction. NOC stands for Nursing Outcomes Classification, and it is a classification system that describes patient outcomes sensitive to nursing intervention. So the NOC is a system to evaluate the effects of nursing care as a part of the nursing process. If you turn to page 267, they talk about anxiety. Anxiety is so common that mild anxiety is considered normal and even necessary for our survival. No matter what area of nursing you work in, nearly every patient you meet will have at least some degree of anxiety. Chronic anxiety has been associated with physical problems such as the risk of a heart attack. There are levels of anxiety. Normal anxiety is an essential reaction to a realistic danger or threat to physical or psychological integrity. And a normal level of anxiety enables us to survive. On the other hand, an abnormal level of anxiety is out of proportion to the situation and lasts long after the threat is over, maybe even causing a person to alter their lifestyle. So anxiety can be mild, moderate, severe, or even disabling. How do we cope with anxiety? Everybody has their own way of coping. Some things we can do is exercise, talk to other people, go to counseling, that type of thing. Engage in pleasurable activities, and that can mean different things to different people. Deep breathing exercises and relaxation techniques, yoga, all kinds of things. Individual people just have to find their individual way of coping with anxiety and stressors. Severe anxiety, we look at defense mechanisms, but defense mechanisms can be maladaptive. We can use denial as a defense mechanism. Denial is refusing to acknowledge the existence of a real situation or associated feeling. We're denying it. Displacement, on the other hand, is when we transfer feelings from one target to another that seems less threatening. For example, if you come home and you push your cat around, but you're angry at your teacher, something like that. That is displacement. You're displacing your anger at your teacher by shoving your cat around. Excess or unrelieved anxiety may contribute to psychosis. Depression. Depression is commonly used in our society to describe feelings of sadness or the blues. Characteristic symptoms and devastating consequences if left untreated. We know in healthcare that depression that goes untreated is setting the person up for some maybe devastating consequences. So we take depression very seriously. 9.1% of adult population in the United States has some type of depression. In your book, this is on page 269. There is a table 13-2, which goes through truths and myths about depression. So I'm again going to point out table 13-3 on page 269. The truths and myths about depression. True, depressive disorders are more common among women than men, 2 to 1. That's true. False, getting on with life will cure depression. That's false. True, spiritual distress is associated with depression. False, everyone likes to talk about how they feel. Not everyone does like to talk about how they feel. True, depression can be defined as a maladaptive emotional response. False, medication is the answer to depression. True, low socioeconomic circumstances and social isolation correlate with depression. False, once depression has been cured, it does not return. That is a false statement. I'd also like to refer you to page 268, table 13-1, levels of anxiety, where they describe mild anxiety and the symptoms, moderate anxiety and symptoms, severe anxiety and symptoms, and a panic anxiety. So severe anxiety occurs, and symptoms that occur with it is that concentration and the attention span are severely limited, so the person has difficulty completing even simple tasks. Anxiety prevents problem solving and learning. They may report feelings of dread, confusion, and other unpleasant emotions. And physical symptoms might include headache, palpitations, tachycardia, insomnia, etc. So that is severe anxiety. A panic attack or panic anxiety, the person becomes unreasonable and irrational and is unable to focus on even one detail in the environment. They can react wildly with shouting and screaming and running around, or they might withdraw completely, depends on the person. Cannot function or communicate effectively. They may feel terror and impending doom, believe they have a life-threatening illness, or that they're going crazy. So just so you look at that and know what the difference between mild, moderate, severe anxiety are, or panic anxiety, and what are the truths and myths about depression. Major depressive disorder is defined as a depressed mood most of the day, nearly every day, for at least 2 weeks, with decreased interest or pleasure in activities previously enjoyed. These people with major depressive disorder have insomnia or hypersomnia. They lose energy, they have a feeling of worthlessness, and they have a diminished ability to concentrate, and they have recurrent thoughts of death. A client with anxiety is completely focused on himself and the need to relieve his problem. He is in which stage of anxiety? Is it panic? Is it mild, moderate, or severe? Look again on page 268. Can you find what describes him? A client with anxiety that is completely focused on himself and the need to relieve his problem. All right. If you look, it is D. We'll go back so you know what D is. D is severe anxiety. And if you look on page 268, that is exactly the description of severe anxiety. So when you encounter someone who you're trying to promote psychosocial health in people. So to do a psychosocial assessment on someone, what you need to do is include all of these categories in their health assessment. And again, this is not the physical assessment, this is psychosocial assessment. The rest of your chapter continues through with nursing diagnoses and analysis of nursing diagnosis, assessment, planning, implementation, and evaluation. So the next thing I will go over in another PowerPoint, which will be very limited, will be spirituality. So here's some interventions, and these are just examples of interventions. And NIC stands for Nursing Intervention Classification. So Nursing Interventions Classification, NIC, and the Nursing Outcome Classification that I mentioned before are comprehensive research-based standard classifications of nursing diagnoses, interventions, and nursing sensitive patient outcomes. So here we're talking about NIC, which is the intervention part. And these are some interventions. Anger control assistance is one. 2, anxiety reduction. 3, coping enhancement. 4, decision-making support. And 5, socialization enhancement. So for the test, you'll want to know what you need in order to conduct a psychosocial assessment. Do you want it to be a quiet environment? Do you want it to be noisy? Do you want interruptions? Do you want to maintain eye contact? Do you want to sit or stand above the patient? All of those types of things. How do you think you would perform a psychosocial assessment on a patient? Know that roles, let's see, in your book where it talks about roles, like role expectation, role performance, all the different types of roles are on page 266. where they talk about role performance and role strain, interpersonal conflict, and interrole conflict. So know what those terms are. What is self-concept? What is a locus of control? And what's the difference between internal and external locus of control? What is self-esteem and what attributes to a low self-esteem? What is self-concept and how can stressors affect self-concept? What is depression and how can a nurse communicate with someone with depression? Again, what are the different levels of anxiety? How can a nurse promote self-esteem in a patient? So all of those are different questions that you will want to study for an exam. And I will end here and I will see you next time. Thank you.